We're now to session 2B, examples of suboptimal use of technologies. That's a little harsh, actually. I guess it'll be a little bit on some things that we really hope were going to work that maybe didn't work quite as well as we'd hoped that they were going to work. So I'm Ted Lawrence, and Jim Hu and I will be co-moderating this session. And we have 4 speakers in this session, 2 of whom will address radiation issues, and 2 will address more surgical issues. And I think that the hope from this session is to learn some lessons about how we can do better at when we implement new technology, getting quality each time and improvements in outcome, and both by increasing tumor control and decreasing toxicity. So our first speaker in this session is going to be Justin Bekelman. He's an associate professor of radiation oncology at the University of Pennsylvania. And he is going to talk a little bit about a topic that we have touched on a few times today. People have used the expression, I'm not a farmer, so horses being out of barns isn't, I'm from New York. So, but in any case, he's going to talk a little bit about how sometimes therapies get started and how we might be able to unstart them and thereby improve overall outcome. So, Justin, here you are.
Thanks very much, Ted. It is a real privilege to be here, so thank you for having me. I'm going to talk about optimizing adoption and de-adoption of high technology to achieve high-value cancer care. And this is sort of riffing on a lot of themes that have come up. I was charged with talking about suboptimal use of radiotherapy, and I have at least 1 or 2 slides on that. But rather than look backwards, I'm going to think about and work with you to look forwards. So I'm going to talk about 4 approaches that we might consider here. Delivery system innovation, provider cost sharing, and I'll define that, price transparency, and evidence generation. And I should acknowledge that this work leverages many collaborative discussions we have in a research group around high-value cancer care at the University of Pennsylvania. And I'm going to try to rate these approaches after giving you examples across 1, potential and feasibility, effectiveness, and then harm. Harm in this case being potential unintended consequences. I'm going to rate them on a star scale, almost like you'd see like Rotten Tomatoes or something like that for a movie. This represents my own opinion and could well evolve after 20 minutes in some discussion. Maybe I'd rate them differently. So what are we talking about here? Well, we know that adoption of radiation advanced technology is rapid. So that's not news. We've seen these slides. We also know that de-adoption of techniques that have been shown to be perhaps equivalent to other patient-centric techniques in terms of cure rates, but perhaps not totally patient-centric, is slow. So what's an example of that? We looked at conventional versus hypofractionated radiation for whole breast. For breast cancer, it's called whole breast radiation, and showed that the use of hypofractionated radiation, which is a shorter course period of radiation, has been adopted very slowly, which means that conventional treatment, the sort of longer course of treatment, which is equally effective, similar cosmesis, but just longer length of time on treatment, is having trouble being de-adopted. So it's sticky. We also showed that in the case of single versus multiple fraction treatment for bone metastases, that even though there's evidence in clinical guidelines showing that they're equivalent, the use of a single fraction is very rare, but more importantly, perhaps, the use of 11 or more treatments is still highly prevalent. So this is asking the question of these sort of extended radiation schedules, and these are just examples of other treatments in medicine and oncology that are slow to de-adopt, and the problem is how slow they are to go away. So these are the 2 areas we're thinking about, and generally we say, and a theme here has been, how do we slow down adoption, and then how do we speed up de-adoption? I'd put it another way, because to various stakeholders, patients included, slowing down adoption is not the goal, right? Many patients want adoption to be quick, quick, quick so they can access new treatments. So I would put it a different way, and I would say that we want the pace of this to be driven by evidence of value. But we can acknowledge some frustration that adoption happens quickly, perhaps too quickly, and that de-adoption happens slowly, often too slowly. So let's look at delivery system innovation. I generally look at this through a framework, and this framework is called the Intervention Ladder, and it was published in 2007 by a group in the UK. And so let's start from the bottom. And this is a way to think about delivery system reform. So number one on the ladder, do nothing or monitor. Number two, provide information. Number three, enable choice. Number four, guide choice through changing the default. Number five, guide choice through incentives. Number six, guide choice through disincentives. Number seven, restrict choice. And number eight, eliminate choice. So if you look on this side of that chart, as you go up the ladder, you increase the effectiveness of that intervention to either optimize adoption or de-adoption. At the same time, if you look on the other side, as you go up the ladder, you decrease choice. You decrease patient choice, you decrease clinician choice. So we have to balance that as we try these various interventions. So let's look at this in the case of de-adoption of extended fractionation, because we're actually already using a number of these policy levers. So if you look at, for example, starting from the bottom up, providing information, well, we've done that. I think we're proud as a community to say that we've written the top five and now an additional top five for choosing wisely, that those could be incorporated into decision support. But the question is, what impact will that have? Number three, enable choice. Well, that might include perhaps giving to patients, making sure they understand there is a choice between two treatments, giving them a sense of what the price is between those two treatments. I'm going to talk about that. Number four, guide choice through changing the default. Well, we might have an opportunity to actually use prescription defaults in our field of radiation. We prescribe radiation like we would prescribe a medicine or a chemotherapy. This is almost like a care pathway that we would help prompt or nudge physicians to do the work, to do the job of de-adoption. Number 5, 6, 7, and 8, we're also continuing to use already in our system. Quality incentives, pay for performance for number 5. Number 6, guiding choice through disincentives. Utilization management, that's a part and parcel of being a radiation oncologist today. And then number 7 and 8, coverage policy, light and heavy. So, this is something we might think about for proton therapy today. Right now, coverage guidelines for proton therapy in the coverage market are already at the top of the ladder when we haven't really explored the bottom of the ladder. So they've already gone to what might be considered a very effective technique, but also potentially a draconian technique that limits choice by either restricting it through coverage or, frankly, just eliminating it. So when I think about rating this, I rate it pretty highly on a scale of 1 to 5 stars, mostly because I know it's feasible. We know it's very effective. Each rung on that ladder can be experimented on and determine whether it'll work. And we already know in some cases it works. The reason it's not 5 stars is because there's harm. There are unintended consequences. Utilization management slows clinical care. Coverage policy as a blanket blunt instrument makes it so that patients with real indications may not be able to access treatment like proton therapy. Now let's talk about provider risk sharing. So I want to describe this in the context of the CMS oncology care model. I'm going to try to do so in about 90 seconds. And I recognize there's a representative from CMMI is Ron around CMMI here, so you can tell me if I got this wrong. So the CMS oncology care model is focused on total cost. So let me try to get this right. It's focused on a 6-month chemotherapy episode in which that entire episode costs roughly $30,000. on average, it depends on the disease and so on, but on average, that 6-month period costs $30,000, of which $2,000 go to the medical oncologist in terms of her professional fees, and the rest is everything else. So that includes chemotherapy, hospitalizations, radiation therapy, ER visits, everything else. So what the model does is it increases by about 50% the medical oncologist professional fees, what's paid to the provider of medical oncology. And at the same time, it makes them in charge, the medical oncologist, of everything else in terms of costs. In doing so, the CMS incentive actually increases the cost of that episode, but CMS makes it very clear, and this becomes illustrative at this point, that they want savings out of this. So the question is, where are those savings going to come from? That is risk sharing. It makes the medical oncologist in charge of everything else during that episode. So that savings, 4% there, is going to come from using generic rather than branded chemotherapies, minimizing hospitalizations, minimizing unnecessary radiation. But you can imagine there are potentially unintended consequences of that risk sharing as well. Can that be applied to radiation oncology? Can that policy lever help us think about adoption or de-adoption? So this is a challenge for us. If you think about radiation-related costs, so that's everything that the radiation oncologist is in charge with within the Department of Radiation, the answer is probably yes. We could change from a fee-for-service payment structure where we're paid each time we turn the beam on to a bundled, this is just an example, to a bundled payment structure in which we're paid a lump sum of money and we're told to just treat the patient. In doing so, let's look at de-adoption first. I could imagine that that could potentially accelerate de-adoption. We might not be treating for extended fractionation schedules as much if we knew that we only had a sort of lump sum of money to work with here. At the same time, it could have unintended consequences. Radiation oncologists could cherry pick. They could induce demand. That means they could look for other patients to treat to make up the difference. They could stint on care. Now, this is not making it defined to radiation oncology. These tenets of economic therapy were developed in the 1970s and apply across medicine. We're just applying those theories of how physicians work under financial pressures to radiation oncology. How about adoption? Many people say that going from fee-for-service to bundled payments will stifle innovation, stifle adoption. I see it a little differently. I see it as that will signal to the market to innovate differently. Signal to the market to innovate differently. So if there was a major push toward bundled payments in radiation oncology, perhaps the market would be nudged toward lower risk in a business sense, lower risk products or less costly products, right? That could accelerate innovation, for example, around less pricey proton therapy units. That could also stifle innovation if those proton units don't have the kind of technology that we're used to today to actually conform the beam to the treatment site. So there are definitely unintended consequences. In terms of adoption, another unintended consequence is actually very challenging in a bundled payment situation to actually figure out how to price that, right? So we'd have to price external beam with proton therapy, with brachytherapy, and provide a bundle. That's actually very challenging to price within such a multi-modality field such as radiation oncology. That can lead to operational hazards. Total cost is the area that our field is sort of stuck in now. And the reason is we're not typically in charge of the hospitalizations. We're not responsible for them in the sense that we don't admit patients to the hospital at most centers. We're not typically responsible for surgery or responsible for chemotherapy. We're a consulting service. And so even though the Medicare oncology care model seems very appealing as a model to share risk, I wonder and question and would like to discuss if it becomes evident to us during the discussion around, could radiation oncologists be put in a position to actually manage total costs, and what would that look like, and how would that help potentially with de-adoption or adoption? So I give it 2 for adoption because of the limitations and feasibility that I discussed, but 3 potentially for de-adoption. Price transparency. I'd like to introduce you to this senior executive at a major company, Ms. Olson. She was featured in an advertisement from Castlight, which is a price transparency company. And her job is to buy health insurance from commercial payers for her employees. That's her job. So her job is to manage the total cost of care as an employer for her job, for her employees. So let's see what she has to say. And Patrick, I'm going to ask you to start that.
In that they offer an opportunity for our employees to go out and seek what medical costs are being charged in our particular area. So if you have an MRI and you need to have that procedure done in Indianapolis, you can check on the pricing and you can determine where you want to go for services and how much those would cost.
Where you want to go for services and how much those will cost. This is price transparency to the point of the patient. I don't do work with Castlight. I'm not paid by them at all. I use this simply as an illustration that brings it home. Imagine, instead of all those numbers there being MRIs, PET scans, you see that? Imagine radiation facilities, prostate cancer, proton, IMRT, right? Hospital-based versus outpatient facility-based. This is coming. And this is a potential tool by which we can manage both de-adoption and adoption. The question is, does it work? They've looked at that. So this was written by Castlight in combination with a bunch of academic researchers in which they looked at and compared what they called searchers, in other words, people who they could verify as having searched for prices. These are patients who were provided the information versus non-searchers. And they wanted to know whether the exposure of price transparency managed to make an impact on the cost of care. And the answer was it did. But it's more complicated than that. So there's a 10 to 15% difference in payments for, between searchers and non-searchers for laboratory tests, which is not a lot of money, but for advanced imaging services, which is a lot of actually patient out-of-pocket costs. So it seems to have an effect both for less expensive and for more expensive treatments. But interesting, no effect on clinician office visits, which suggests that patients are looking for things beyond price when they're looking at the patient-physician relationship. I think that oncologists can use that to think about combining price and quality. Also notice that in this Castlight advertisement, it's all about price transparency, but it wasn't about quality transparency. There was no quality associated with that. So I'm actually really excited about price transparency and how it may impact oncology, and specifically radiation oncology. I'm not sure that it has a role in adoption, but I'm pretty sure it may have a role in de-adoption because I have a hypothesis that when patients have a real sense of the different treatments and their costs, that they will help the oncologist make decisions that are patient-centric. Let's lastly talk about evidence generation. This gets back to some of the proton discussion. We've been talking mostly around de-adoption here, and now this slide is around adoption. And so this chart illustrates 3 prevalent malignancies and the randomized trials of proton therapy that are either currently accruing or are shortly going to accrue, and what the differences are. So in prostate cancer, there's the particle randomized trial. In breast cancer, there's the RADCOMP pragmatic randomized trial. Lung cancer, there's RTG 1308. They're funded by different sponsors, and the design of the trials reflects that. So the particle trial, and I'm involved in both the particle trial and the RADCOMP trial. The particle trial is funded by the National Cancer Institute in coordination with Mass General Hospital. Dr. Eustathio is head of the coordinating center and the PI of that. The primary endpoint is a patient-reported bowel function endpoint. The PCORI grant is a pragmatic trial, and the Primary endpoint are major cardiovascular events and relapse for breast cancer and in lung. More of an efficacy trial with a very hard endpoint of survival. So one question is, are these patient-centric? And the answer is, sure they are. I think they're all equally patient-centric for different reasons, even though the primary endpoint very different across the 3 trials. Second question is whether they're payer-centric. So again, I'm involved in both prostate and breast, and I think they're very payer-centric. But when I listen to payers talk about them, sometimes the payers say to me, well, we're less interested in patient-reported outcomes, and as you can see, there's 5 stars over on survivor. We're much more interested in survival. The timeline and the Achilles heel of these is that the timeline is long. Results will be out 5 years for the breast trial, probably over 10 years from now. I'm not sure that that is payer-centric, but the challenge of cancer care is that cancer works on its own timeline. And we're not going to have 30-day operative mortality. We're not going to have these quick endpoints to make decisions. We're going to have to follow the natural course of the disease. And also the fact that radiation has late effects. So as part of this, I want to highlight a theme that came up in our discussion of the device industry and highlight the fact that there really is a difference in R&D and that reflects the regulatory environment that the device manufacturers are under. So, Varian, Electra, IBA, all are in the sort of 6 to 7, 10, 11% area of R&D spend, whereas in the pharma world, that's on average in the 21, 20%. And so if you look at the top quartile, which all these radiation device companies are in, if you look in the top quartile of medical products, they're right there at 10% R&D spend. But if you look at pharma, which has to pay for evidence generation as part of its regulatory environment, it's at 30%. If we all of a sudden turned a switch and said, you know what? Now the device industry is going to have to do something different. We have to put into FDA comparative effectiveness research. That's going to have major effects down the entire supply chain. The R&D costs are going to go up. The price of equipment is going to go up. In the end, someone's going to have to pay for this, and it's probably going to end up being the providers and ultimately the patients and the insurers anyway. I'm not saying this is the ideal environment, but this explains a little bit of where we are. I also want to give a sense of how we've begun to think about evidence generation and linking it to payment policy. And this is a schematic from Peter Bach's article in 2010 that we sort of extended in 2014 for proton therapy. But this was an idea about how Medicare could use comparative effective information in its coverage decision. So if you go from top to bottom, if there is evidence of a superior comparative effectiveness trial, then they would get usual pricing. But if there was evidence of comparable comparative clinical effectiveness, they would begin with reference pricing. So this is payment equal to that for the equally effective alternative. We often use that now in proton therapy. Some payers have decided that they want to do reference pricing. In other words, they'll pay for proton and IMRT at about the same rate, such that, and then they insist that patients be on a trial. And then they tell us that they'll adjust the rate based on evidence of the trial. The third is insufficient evidence. So for those that are, for technologies that have insufficient evidence to judge comparative clinical effectiveness, Dr. Bach called for dynamic pricing. So this is payment based on existing formulas, effectiveness reevaluated after 3 years. In other words, it's like ticking, right? They're saying, okay, we'll pay for it as we would pay for it. And then within 3 years, we want an answer. This is just an awesome conceptual model of how to think about things. It's really problematic in cancer. We can't do trials in 3 years. We have folks, very senior folks here. I can't see where Jim is, but we have senior folks here from RTOG, NRG. Like, those are not the time scales or timelines that we conduct randomized trials in cancer care. So while this is appealing, it's potentially limited for us, and we probably have to expand on this. An extension of this, again, and I used to work with Dr. Bach at Memorial Sloan Kettering, so I take a lot of his ideas and I just apply it to proton therapy or to radiation. So he published something called indication-specific pricing for medical oncology, and I just want to leave you with this idea that a natural extension of the idea of generating evidence of value for proton therapy or IMRT is the idea that we could potentially price these differently based on that evidence. So if you look at this 2x2 table where the left column, the left side is the radiotherapy complexity, and the bottom is care coordination complexity, and you might say prostate proton, prostate 3D, and breast cancer might all be paid in the lower left-hand corner, whereas in the top right-hand corner, indication-specific pricing would suggest that we might pay actually for pediatric proton, where everyone seems to agree that there's at least evidence, if not theory as well as evidence on the benefits of proton therapy, but also we should be paid as radiation oncologists for the fact that it's really hard to coordinate patients for anesthesia and so on, and that complexity is time and effort. And that might put us into the top right-hand corner. Head and neck IMRT or proton therapy, CNS proton therapy. This is a developing thought, and I'd love to have your comments on it. So I would put evidence generation actually at 3 for adoption because it can drive adoption, only 1 for de-adoption because honestly, when we publish articles showing it's not really as good as we thought it was, it's very hard to get rid of it. So it really doesn't work for de-adoption very well. But when you link it to a reimbursement under a dynamic pricing model, well, it could. It's potential, and that's really what could drive it. So in conclusion, I think my position at this point is that adoption and de-adoption should be based on value, that we shouldn't expect the pace to be speedy or not speedy, but that we should expect it to respond reasonably to when evidence is generated, and that we may get a more potent response if we link evidence to payment reform. Short of that, I actually think that delivery system innovation around this innovation ladder idea is an area that not only in radiation oncology, but throughout medicine, we haven't addressed well enough. But I would hope that as we do so, we recognize that as we go up that ladder, some of our reforms are going to fail. Some of our reforms, I was just talking with Ann Geiger, and I was saying that we should really talk about personalized delivery. Some of our reforms will work for some disease sites and patient groups, but not for others, so there would be heterogeneity of treatment effects as we go up that ladder. Ultimately, if we don't respond to the sort of less draconian techniques, that we have to realize if we don't put it up that ladder, someone else is going to start going up that ladder. Thanks very much.